6?
Yeah.
Okay. Hi everyone, welcome back. This is part 2 of us talking about pericardial effusions and tamponade. So today we're going to be talking about some potentially special situations or not so special situations for our patients. So the bad situations where we need to really consider what we're doing, and some things that might make it a bit trickier compared to what we were just talking about last time. We'll be talking about at what point we're draining these, whether tamponade is genuinely just a clinical diagnosis nowadays. Controversial. We're going to talk about how we would actually go about draining the effusion. And lastly, we're going to go through a couple of complications that are not talked about that much, I don't think, that can happen after you decompress the pericardium. So, Emma, should we start talking just about a few special situations? We talked about how we would conventionally look for an effusion, and talked about the sizes and things last time. But there's some situations where we need to be think a little bit differently or have a high index of suspicion.
Absolutely. So for me, Chris, the big one that we need to be aware of is the pericardial effusion and tamponade associated with aortic dissection. So, if you are seeing things, even with basic visual assessment, if you're seeing a big dilated aortic root, if you're seeing aortic regurgitation combined with a pericardial effusion, and a bit of a dodgy clinical story for that, you've got to be suspicious for dissection and go looking for that. And obviously TTE is specific if you see the flap, but it's certainly not sensitive. And so perhaps modalities such as moving on to transesophageal echo, obviously CT, aortogram if the patient's stable enough, etc., etc. But that would be one scenario where you have to have a really high index of suspicion, and a tiny slither of pericardial fluid can obviously cause cardiac arrest.
And I guess it's that rapid accumulation, isn't it? It's a sudden thing that happens. Exactly, and so you get a small amount of fluid there, and it's just occurred like that, and that means that they are really unstable. So we've got a case here of someone who actually has a dissection. So just talking through this image, this is a parasternal long axis view. Actually, the descending aorta looks a little bit big as well there. And then, this is the left atrium, mitral valve, left ventricle. The descending. Yeah.
Excuse me.
Yeah.
Yeah. That's like a little bit big. It's massive. What's he looking at?
And then we do have a very big ascending aorta, and you can see that you've got the dissection flaps here, and then you've got this pericardial effusion here. And although you don't necessarily have all of the classic kind of collapse of that right ventricle, this person was super shocked. The other situation, this is really important, and it's not the easiest to see, but definitely if it's big and there's decent windows, you often can see it, is if you've got someone who you think you're about to thrombolize for something that you're not sure about, they're short of breath, they're a bit shocked, you think, could it be a PE? Definitely just have a look with an echo first, because this dissection mimics lots of other pathology, doesn't it?
And we'll talk about dissection in a whole episode or two, because we've got some lovely cases of that. But just to point out as well, Chris, you said that the ascending aorta looks big, and it does, and you can use these markers along the sides. So this is 1, 2, 3, 4, 5, almost 6 centimeters, right? So once you start getting, obviously the upper end of normal is different if you're male, female, depending on your body surface area and things like that.
Age as well.
And age. But rule of thumb is generally if you're getting above 3, but in that territory, then just make sure that you're measuring it and quantifying it.
And from a simple eyeball perspective, people use that rule of thirds, don't they? So they look at the RVOT, the ascending aorta, and the left atrium, and you can see here that the ascending aorta is just so much bigger than both of them.
Really nice, And the dissection flap kind of gives it away.
It does give it away, and there was also quite a lot of aortic regurgitation here too, but I haven't included that, unfortunately. So that kind of leads on to another case that is something that you need to be really wary of, and that's your post-cardiac surgical patient. These patients are so difficult to image and so difficult to see if there's any collection. And I've just included this as an example of someone who's got a big posterior collection, and this is all blood, but this blood is all clotted and it looks so similar to the appearance of the myocardium that it's super easy to miss it. And actually this had been missed by someone because it was just a cursory look, and they said, oh, there's no hypoechoic area on the around the heart. So this is something that you can miss very easily.
I can easily see how that can happen. So yeah, definitely be mindful of that. Yeah.
And then the other thing just to say is that whilst you can have tamponade as the key thing that you need to be worried about, then you may also have some other associated features with it. So this is a patient who I was asked to go and see in the middle of the night, who had a big LAD infarct, had decompensated a bit from a hemodynamic perspective, but also worsening hypoxemia, a bit of agitation, and I was asked to go and help intubate her because she probably needs to be intubated on ICU. And we did a quick echo just to make sure there was nothing else going on. She had a balloon pump in and everything. Classic post-cath lab patient.
Can I just point out the balloon pump for everyone?
Yeah, absolutely.
You can see it here, just flapping around in that descending aorta.
Yeah.
See that structure, the bright structure.
Yeah, definitely. There. Nice. So yeah, the post-cath lab deterioration, a pericardial effusion is something we need to be looking at.
It's one of the first things you look for.
Yeah, definitely. But the other feature on this echo that was slightly unusual and a bit of a surprise, she had really hyperdynamic basal segments because she had a big LAD infarct, and that ventricular interdependence had pushed over her septum into her left ventricle. And because she had hyperdynamic basal segments and she had that shift of the septum, then she actually started to get some systolic anterior motion of the mitral valve and LV outflow tract obstruction. And
because the balloon pump was in.
Which didn't help the situation at all. So if I just go back to the image and just show you, so you can see it's quite difficult to see. Put the probe on and we were a bit concerned immediately, so there's a bit of motion there, I apologise. But you can see that this anterior mitral valve leaflet is being drawn up to that proximal septum there. And you can put some pulse wave Doppler over there, and you can see this kind of dagger-shaped continuous wave Doppler over the LV outflow tract, and you can see that this is a very high velocity, this dagger shape. But we won't go too much into this because it's something we'll have to cover in a whole episode in itself, I think. LV outflow tract obstruction.
Yeah, one of our favourite topics.
So moving on from these special situations, so I guess, Emma, you're the specialist here.
Don't play that card. Where the rubber meets the road.
Yeah,
right. When do we drain it?
Yeah, exactly.
My rule of thumb, just keeping it super simple. If you think about draining it and you leave your shift, you're going to be coming back in at 2 a.m. to drain it. Yeah. So if you're concerned enough to think about a drain, they probably just need a drain, just to keep it. I don't know. There's no one size fits all here. Hey, it's risk benefit analysis. Sometimes it's taken out of your hands because they are so unstable with that obstructive shock picture. Yeah. But other times you do have a little bit more. Vacillation and discussion about it.
And I guess it's also that not everything on ICU is as simple as that all the time. You may have someone who is shocked for a number of reasons. They could have a lobar pneumonia, they could be a bit vasoplegic from sepsis, they could have a bit of LV outflow tract obstruction, a bit of stunning of the left ventricle. Could it be this? Could it be that? And definitely the cases where there's also been some pericardial fluid, even if there haven't been the classic features, if you've had someone willing to come and help you and drain it, just to take that out of the equation, then it really simplifies matters, or at least takes one thing out of the equation. And clearly, it's not a completely a procedure without risk, but if you're going to if you've got that effusion there and it's complicating the management of the patient, then it is nice just for that to go.
I think so. Yeah, I think so. Taking out of the equation, as you said, and especially it's all about the trajectory of the patient, right? So if you're doing other things and they're still getting worse despite what you're doing, and there's pericardial fluid there, you're for sure going to drain it. Yeah. And sometimes you see, right, even if you just take 5-10 mils off, that they get better.
Exactly.
And then everyone feels better, the patient feels better.
Hopefully, yeah. And there's different approaches that you can take for drainage. I mean, the classic one's a subcostal approach, blind technique. Or you can use ECG guidance with that as well. But definitely with the more widespread use of POCUS, people have started to use other approaches, haven't they? Parasternal approach, apical approach, or just a combined approach using ultrasound as well. So what would be your go-to, or do you not have a go-to? Is it patient dependent?
Yeah, it's patient dependent. I've not done a parasternal drain. I have seen them being done. I must admit the one that I'm most comfortable with is subcostal. I think most of us probably are, right? Because the apical approach, I think, has its merit, especially when you don't have much of a window in your subcostal.
Yeah.
You need to go through a lot of liver, the diaphragm, there's more things you need to go through. And sometimes, like with this case, we're going to show the apical window is beautiful.
Yeah.
The key thing that you need to do is avoid the LAD. And no, there have been, case reports and complications involving that. And so the last thing you want to do is prang that LAD. But if you know what you're doing with it, and you use that orthogonal plane with your your ultrasound in the subcostal region, you get that 90 degree and you angled away from the LAD. It does take a little bit of training and practice. It wouldn't be something that you would be doing on your own without being taught how to do that and seeing it being done, etc. And of course you need to take into consideration how the patient is otherwise. Are they terribly coagulopathic? What are you most comfortable with, etc. But yeah, those are the three main approaches, aren't they? I tend to go for subcostal if I can.
Yeah.
If there's absolutely no window and there's a lovely apical, I have done a couple of those. But yeah.
Yeah. Well, I guess there's the other things like using agitated saline and using echo guidance or assisted echo-assisted procedure, so that we can actually see where the needle is to where the wire is. You can see the dilation, and then you can use the agitated saline to confirm the placement. And I guess if you're in an arrest, would you still be using agitated saline? Or?
I did actually, yes, I do, because the last thing I want to do, it's one thing to put a needle, into the RV. It's another thing dilating it.
Yeah.
So I do, that extra 2 seconds that it takes to do it saves a whole heap of trouble after. Yeah. So I do. Yeah.
Yep, fair enough. Well, we've actually got a case that we were both involved in a few weeks ago. Was it? A few weeks ago now. And we're kind of showing you the steps that we did. So we did the subcostal approach for this. This was a patient who was transferred from another hospital with a acute liver failure of unknown cause, really. A bit coagulopathic.
A bit.
Well, she was coagulopathic. We're just trying to downplay it for the fact we did a pericardiocentesis. So she arrived and she was in cold obstructive shock, diaphoretic, tachypneic, couldn't get SATS tracing, and obviously the first thing we do is grab the echo probe and make sure she hasn't got a big pericardial effusion, or see how her heart's doing anyway. And we found a huge pericardial effusion. So if we just go to the video now, then you can just see that this is an enormous pericardial effusion. So this is a subcostal view initially. And then if we...
So she's clearly had it for some time, Chris.
Clearly had it for some time.
She's just had that tipping point.
Absolutely. And then if I start playing it, so you can see this is a plaques view. Sorry, that's a plaques view. And then here's the apical view. So
I was saying about that lovely window that you would have.
Exactly.
With your apical
for sure.
Approach.
But we actually did a subcostal approach in this lady after having some blood products, I'd just like to point out. We kind of went in with the needle from a subcostal approach, and then as soon as we got aspirate, it was hemoserous aspirate, and then we injected some agitated saline. So you can see this. You could see the agitated saline here. So we have got 10 mils of saline with kind of 1 mil of air in it, and then agitated it between two syringes through a 3-way tap, and then injected it through the needle to make sure we're in the right place. Then the wire went in. So you'll see the wire soon.
You can see it so beautifully because you're at that you're at that 90 degrees with the wire. So holding the echo probe in the apical window, and then the drain going in through the subcostal window. Yeah,
and so we dilated and then put the drain in, and then just to confirm, so the tip was there, but just to confirm, we put some more agitated saline in, and then straight away you can see. I think we've got another image. So straight away after taking, I think 500 mils off, you could see, although there was still fluid there and there was still kind of quite a lot of motion of the heart within the pericardium, there was a significant reduction in the amount of fluid there.
I think trying to just get involved in as many of these in non-critical circumstances as possible,
exactly.
just to get that muscle memory, that confidence in doing them, because often when you need to do them in intensive care, it's pretty hairy and it needs to be done pretty quickly.
Pretty hairy situation,
and echo just makes everyone feel a bit more comfortable.
Yeah, and also on ICU there will probably be about 10 people watching you do it, won't there?
Oh yeah, always.
So, we want to drain this patient. We want to drain it as soon as possible, as quickly as possible. But there are some potential complications of the drainage that are potentially under-recognized. And you have that big kind of relaxation moment after you've drained the effusion, but you still need to be aware of what's going on.
It's a bit like when you intubate someone, isn't it?
Exactly. Yeah. You've kept them stable.
The asthmatic, and no, I'm kidding.
and then it's just the beginning of your trouble.
IU ratios 1:1.
Yeah, exactly. So there are some complications to be aware of, and the first one we're going to talk about is called pericardial decompression syndrome. So. Pericardial decompression syndrome is where you get this paradoxical worsening of your hemodynamics after drainage of the effusion, and this is something that can lead to either LV or RV dysfunction, and was initially described as being kind of a cold shock with pulmonary edema after drainage, but this was back in the 80s, so we clearly can use echo now to identify it a bit with a bit more speed, I guess. There isn't really a brilliant explanation. There's a couple of hypotheses. This could be to do with a change in your ventricular interdependence. They suggest there could be a preload afterload mismatch, so the SVR could still be really high because it's being compensated for the tamponade. This could also be an autonomic imbalance, again SVR being very high, or it's proposed that it could be to do with some coronary artery ischemia. If that pericardial pressure is so high that it's compressing the perfusion, then the coronary arteries, then that may lead to it. But these are all hypotheses. No one really knows exactly what it is. It's probably a combination between all of the above. And this is an example of that patient that we drained who afterwards, this was 2 days later, and you can see this is just using a Plax view, but there's still a little bit of residual fluid there. But the right ventricle looks dilated.
It's almost
there.
Physiological, that, isn't it, Chris?
Yeah,
it
exactly.
Disappears.
Yeah, and I think that's probably the drain in there at that point. And you can see that right ventricle is dilated and it's really not doing very much. And this really held this patient back for a couple of days at least, while that right ventricle was recovering.
Yeah.
So that's something to look out for. And even in this case, we did try to limit. We tried to limit that risk by only draining a small amount at a time. We drained 500 immediately just to gain a bit of control, and then we kind of incrementally drained a bit more. But even despite that, she developed this.
Yeah. Another complication after draining a pericardial fluid is the dreaded complication, really, of a really terrible process called effusive constrictive pericarditis. This again is a patient we've had recently who as a young patient and came in short of breath with a pericardial collection, some features of tamponade. The drain went in, everybody relaxed, thinking they'll get better. And unfortunately, they didn't get better. In fact, their symptomatology got worse. They developed worsening shock, mainly backwards failure, actually. So became short of breath, hypoxic, with a big leg swelling and some hepatomegaly, rather than forward failure. We'll have a whole session on restriction versus constriction, but just very briefly, we can see here that we have this septal bounce, this septal wobble. Looks like it's having a little party, doesn't it, in the chest? You just see it sort of bouncing around there. So the key thing is seeing that, and then combining that with, I don't know whether she had a dilated IVC, but if you see septal bounce with a dilated IVC, that, in the clinical context of just having had a pericardial effusion drained or being post-cardiac surgery, or you've had previous radiation, or you've got tuberculosis, these kind of things, you would absolutely be suspicious of that. But there are a couple of other cool echo features to also be aware of as well. This is a real pathognomonic feature of constrictive pericarditis, which again we'll dig into a little bit more later. But usually your lateral annulus, the velocity of that is usually much higher than your medial annulus. And in constriction, obviously that lateral annulus is going to be tethered, and so you get a drop in your lateral annular velocity, and in fact your medial velocity then increases above your lateral annulus, and this is called annulus reversus. So if you see a patient, and I remember, I think it was one of J.O.'s lectures where he talks about if you see a patient with symptoms and signs of heart failure and they have a medial E prime of more than 8, you've got to think about constriction, because that is just, that's not normal to have a normal E velocity, prime velocity, in the context of having heart failure. So that's a top tip as well. But certainly that annulus reversus, so mitral E prime velocity being higher than lateral E prime velocity, combined with a septal bounce and a big dilated IVC, you've got to think about constrictive pericarditis as a complication, because it does happen. We've had a few cases, 2 in the last month, of pretty significant constrictive pericarditis. There are other features to talk about, which we'll get into next time. I've spoken far too long. Apologies.
Yeah, we'll move on to that another time, because I think for the sake of time we'll have to end it there. But just to recap, we've talked about what pericardial effusions look like. We've talked a little bit about the fact that it's rate of accumulation rather than just the presence of it being big, small, whatever. If you're only a basic echo trained, then remember that seeing that pericardial effusion really gets you that step ahead in phoning a friend. And if you've got someone who's shocked, then as Sam said, say they're shocked and say, look, we've also got pericardial effusion. We've talked about some times when maybe you don't want to drain it straight away, or you need some surgical intervention for that, and maybe some complications that you can get after drainage, that even though you've got that drain in the right place, you've confirmed it with your agitated saline, you can't just quite relax straight away. Yeah.
I mean, I think the decision to drain or not to drain is really individualized and needs to be, targeted at the bedside, and a few things to consider there. As all things.
So we'll leave it there. Well, thanks very much, and we'll see you next time.